So my name is Mark Hughes. I'm a co-chair of the Ethics Committee here in the hospital. Welcome to the first installment for 2017 of Ethics for Lunch. This is co-sponsored both by the Ethics Committee and the Berman Institute of Bioethics, so we appreciate the support of both. And today we're going to be talking about taking care of a patient who's in the hospital for a very long time. I'll read the case in a moment. We have a distinguished panel to talk about it, and then also get your input about these challenging cases. Just as a reminder, if you want CME credits, there's this special code that you have to type in on your smartphone that you can text message and get credit for participation in the session. So I will start by reading the case, and then we'll go from there. I'll just also point out Donna Richardson, who is one of the nurses, NC3s, in the surgical intensive care unit, had to work in the unit today, so is not able to be on the panel. So we hopefully will bring her back for another session, because we really think that's important to get the frontline nursing input about these kinds of cases. All right, so this is a 71-year-old male who in total has been in the hospital for 6 months. He had been hospitalized at another institution, another hospital, where he had been admitted for urosepsis. He had been undergoing treatment for locally advanced prostate cancer, so getting radiation therapy for that, and then got this urinary tract infection that led to sepsis. During that hospitalization at this other institution, he developed multiple respiratory complications, resulting in the need for mechanical ventilation. Because of the prolongation of that, he required a tracheostomy and also a feeding tube, a gastrostomy tube, to keep him going. He did have a prior medical history besides the prostate cancer of hypertension, diabetes, obesity, and COPD, emphysema. And that hospitalization, because he was bedbound for so long in the intensive care unit, he developed a large sacral pressure ulcer, stage 4, and as well, because of his respiratory complications, a loculated pleural effusion. With these additional problems and his really not seeming to get better over a 2-month period at this other hospital, his family requested that he be transferred to Johns Hopkins to see if we could get some of these problems resolved. He has a wife and 3 adult children, and all of them want him to get better. They want him to get back to his prior functional state, prior to initiating the treatment for the prostate cancer, and interpreted that as we want him to be able to walk and get around, take care of himself, and be cognitively intact, like he was before going in the hospital. So he gets transferred to Johns Hopkins to our oncology intensive care unit, and for the loculated pleural effusion undergoes a thoracentesis, so they drain the fluid, discover that it's infectious, so he gets antibiotics for that. Eventually, with ICU management, he's able to be taken off of a ventilator, placed on a T-piece, so he's just getting air delivery through the tracheostomy, and eventually transferred to the medical floor in oncology. During his recuperation, he develops Clostridium difficile colitis, a serious infection leading to diarrhea and dehydration, and in the midst of that, has a cardiac arrest. He is successfully resuscitated and brought back to the ICU. Then a long hospital course in the ICU for several months. During that period, his mental status is waxing and waning, so he's got some elements of delirium. While he's there, he develops a fungemia, so infection in his bloodstream of a fungus, requiring 42 of a prolonged antifungal treatment course. And then bowel ischemia, so while he's been septic and having these other problems, he gets lack of blood flow to his intestines. That leads to a perforation, requires emergent surgery for that. That results in an open wound that has to heal gradually, as well as a colostomy tube. He has signs of liver failure, renal insufficiency while he's getting all this ICU care, but more recently those seem to be improving. So there are some ups and downs in the course of the hospital stay. He's continuing for treatment of his pressure ulcer in the sacrum and trying to get him mobilized, trying to get him more functional with physical therapy and occupational therapy, but that's been limited to some degree by his delirium, how much he can be able to participate in the therapy sessions. So he's been at Hopkins for 4 months. His wife has been his surrogate decision maker throughout. When he's been able to participate, he will be involved, but most of the time with him being critically ill or having delirium, she's been the decision maker for him. He's never completed an advance directive himself previously, and his wife has been consistent throughout. We want him to get better. We want him to get home and be back to what he was prior to all this happening. So family meetings have occurred with various healthcare teams in the different settings that he's been, periodically over the course of the hospitalization, especially when he's had these acute events needing surgery and so on. Each time, his wife and his children have been consistent. We want him to get back to his previous level of function. The team, knowing that this has been a long haul already, is concerned about how feasible is it that he can get back to his previous level of function. As it says here, 1 step forward, 2 steps back. He makes some progress, but always some other event happens that makes him more clinically deteriorated. So this is a challenging case for all involved, and I'm going to turn it over to the panel. I'm going to have Louise Knight start and see your first suggestions about this case.
Thanks, Mark. So I'm Louise Knight. I'm the Director for Patient and Family Services at the Kimmel Cancer Center. And so we're going to take a shift a little bit from...
It looks like it went dead.
So we're going to take a little shift and talk a little bit about the family first. So we don't know a lot, but we know a little bit. So there's a wife. We're going to assume of multiple years. We've got 3 adult children. What we don't know is how they function as a family. We don't know how they make decisions, how they are structured within the family. So all families have a structure and sort of a dance that they do as how they operate, how they choose to have sort of healthcare hierarchy. We don't know much about them, but those would be things that you'd want to know as you were thinking about this case and being the practitioner on that. We also don't know the medical history of the family, so we don't know how much chronic illness has been in this family. We don't know a good deal about their 3 children and how they have coped and dealt with gas healthcare issues, and he's got several of them. And so they're factored into the comorbidities of this case. But again, we don't know very much. We don't know their work history. We don't know their financials. And all of those variables are important considerations as we talk about this case going forward. We know very little more about him other than he's got a newly diagnosed prostate cancer that has begun its standard radiation therapy. And then suddenly he has a major event with urosepsis, which brings him to his hospitalization. So this chronic illnesses that he's been coping with, we now have a new sudden onset, and that sudden onset has moved him very significantly into the healthcare system. And 4-month stay at Hopkins, but he had a 2-month stay at an outside hospital. And you can see from the write-up the complications that he experienced, but you can also just perhaps fantasize a little bit about what that family went through. So here's a guy who just came in for his standard radiation therapy. He's doing well, and all of a sudden he gets urosepsis, and he is not only inpatient hospitalized, but now he's trached. He's on a ventilator, he's trached, and we are off to the races for this family. We are trying to figure out and get some ground with underneath them again. We're going to assume that over those 2-month period of time that relationship with that outside healthcare system that had some probably ups and downs in the conversation of why isn't that getting better. And at 2-month point in time, something has triggered this family to leave that outside hospital and request a transfer to Hopkins. So something gets to be the trigger point for that family, that the tolerance of staying within that health system and continuing with those healthcare providers, something triggers that they've now requested this transfer. They've now come to Hopkins, and this is a brand new but very large and complex medical system that we have. And we're going to again add a little bit to our conversation. We're going to assume that perhaps he was at a community hospital and now he's come to Baltimore. And this family is now trying to figure out their location from a garage here to wherever Dad is. And so appreciating the complexities that really does present to folks. There are other complications to continue and keep in the back of your mind as you think about how this family is adjusting and coping. Over that 2-month period of time, whatever income was coming into that family from those 3 children may have been limited because of their desire to be with Dad. At his age of 71, we're going to make some assumptions that he's Medicare primary and that he's got some Social Security income. But we don't know that for sure, considering our aging population is working longer and longer. We are often now seeing people well into their 60s and early 70s still working as primary. So we don't know a bit about his finances and the family as all. Often when people come to Hopkins, they're looking for something. And we know what they're looking for. They're looking for the solution and the answer that the outside hospital was not able to provide. And they're expecting that it will happen here. And so for 4 months, this family has been expecting that answer to come. And with every up and down and movement forward and backward, that family has been expecting that the outcome will turn around and the story will get better. That is not an uncommon story, and I know probably every head in this room would nod that you've heard that stated over and over with cases that you've seen. So I don't think this family presents themselves any differently than any other family who's expecting us to be able to give them the wish and the desire. She is looking for a state of health prior to this hospitalization of good 6 months ago. And in that point in time, she expects them to be fully functional. It is a hard conversation to help somebody understand who was well at one point, got your sepsis, and here we are. That family's looking for the story to be able to be put concisely into a dialogue, maybe their family narrative, but a dialogue that they can repeat to others who say, what happened? A family needs to be able to summarize it in a way that makes sense to them and that would make sense to the party that they're telling. There is some honor in that, so there is a code of honor to be able to say that they did absolutely everything that they could for Dad in retelling the story. We also don't know culture of this family, we don't know religion of this family, and that could play a larger or more minor role depending on the culture and the religion of the family. So I'll stop there and let my colleagues go forward.
Great, so I'll have Lee go next.
One of the things that I was struck by that you were sharing, Louise, is this notion, or the importance of this notion of did I do everything that I could? I'm supposed to introduce myself first, though, so before I get into that. My name is Lee Doherty-Biddison. I am faculty in pulmonary critical care. I spend all of my clinical effort in the medical intensive care unit. So we see patients not unlike this all too frequently. And then I have an administrative role in the chairman's office as the vice chair for clinical affairs. And I work with the other illustrious folks up here on the hospital ethics committee as well. So it's a privilege to be able to be here today. You know, I was thinking as you're speaking, Louise, about this notion about what the goal of the family is. And very often is that pie in the sky, I don't want that to sound too pejorative, but often it is a pie in the sky solution to the problem that we are pretty clear very early on we can't provide. But I've found often in situations like this, it is as important to be able to say we did everything that we could for our family member. And that's actually a response that as providers we can, or information as providers that we can offer. And reassure families that yes, you have done everything that you could. You have asked all the right questions. You have turned over every stone, and you could be reassured of that, because that's really an important piece of their processing. I just want to spend a couple of minutes highlighting a couple of issues that I think are important on the provider side in this particular case. And I absolutely want to have some dialogue with all of you just to get your reactions and responses. I know there are many providers and family members in the group here. The first challenge, I think, in this context for, again, on the provider side of things is this notion of moral distress. So anybody who's in the bedside for any period of time has been in this situation of asking him or herself, is what I'm doing the right thing by the patient? We often say or I often say in some of my conversations about goals of care, there are many things that we can do in medicine. It doesn't mean that we should do that. And we find ourselves not infrequently in situations where we're trying to figure that ourselves. I can keep this patient's blood pressure up. I can transfer them to the ICU again. I can give them another course of antibiotics. Does that mean I should? And that generates a tremendous amount of distress. In a case like this one, where a patient had a really complex course, and it seemed, at least to the providers, that the end result is quite clear. Continuing to pursue aggressive care can generate a great deal of moral distress, and often does. The second issue that I think is important is the challenge of communication in these situations, and I want to talk about that within the team. So we live in an academic environment in which the players change on a good scenario every 2 weeks, often much more often than that. The attending will rotate, the house staff will rotate, nursing comes on shift and off shift. The patient is going back and forth between units where they may or may not have a similar team or any portion of the same team. And those handoffs, and we've all been part of them, even at our best intention, are often quite inadequate. Because that conversation that I have when I hand off a patient to Mark, and I had this conversation with the family, we agreed on X, Y, and Z, doesn't include the nuance of X family member was there, they seemed very upset with that situation, and I think it's worth more follow-up, just based on the practicalities of time, as an example. And that you just cannot possibly hand off all that nuance, and that adds a layer of complexity here. The other thing is, in situations like this, decisions about goals of care can be very fluid. And so there can be a great deal of tension between the physician team and the nursing team because the conversation is fluid. A change may have happened that was inadequately communicated to another part of the team. And that can, part of the nursing staff, even if it's only for a few hours, can be acting on sort of one set of assumptions when the physician team has changed those assumptions. It makes a big, big difference, again, even if it's only a short period of time. And that's incredibly complicated. And then we have this notion of, we get all the best heads in the room, we have this conversation with families a lot. You're going to see all the best experts that we can possibly provide. They're going to come in. But they might tell you different things. And we can manage that as best as possible, but it's still going to happen. And so we have to think proactively about how we manage that, how we tell our families about those things. I think that is really a big challenge. And all of this relates to something else that I want to highlight, and that is the impact on the team relationships. So however decisions get made here, they can either be trust building, that is within the team or between the team and the family, or trust diminishing. And that can't be underestimated, because even if we all walk away from a particular interaction with a family, I'm glad that's resolved, moving on, the memory of how that was processed, of whether my attending had my back, or the nurse manager had my back, or X consultation had my back, so to speak, in those conversations, carries with us and impacts down the road how we engage with those colleagues in future critical interactions like this. The last thing I want to mention is this question that again I think is really worth discussing, which is what are the things that could have happened earlier in this hospitalization that would change where we are when we come to the end of this case? Maybe everything was done perfectly well. Maybe there are things we need to think about, sort of almost by protocol, as it were, doing a little bit differently. You could even ask the question about whether or not this patient should have been transferred to Johns Hopkins. I think that's actually a really interesting ethical question. If the person receiving the PAL transfer request had reason to believe, based on their conversations, that everything reasonable had been done for this patient, are they morally obligated to accept the patient and transfer or not? And maybe that's, one way of looking at it is, well, that's a cop-out, then you just leave this challenge to wherever the patient is. On the other hand, if you think about how we expend our resources and impacts on teams and communication, all those things, maybe it's an important question for us to answer. And then a corollary to that is, if the patient is transferred, what are the flags or signposts, perhaps is a better way to put it, in the history from the first hospitalization that should lead us towards a particular way of establishing communication very early on, and building towards that really healthy therapeutic relationship with the patient and family that moves towards an end that is meaningful and positive for everybody who's involved.
So good afternoon, I'm Cinda Rushton. I'm the Bunting Professor of Clinical Ethics between the Berman Institute School of Nursing and co-chair of the Hospital Ethics Service. And I'm a nurse. So I find this case a familiar story. Often we are called to be involved in situations like this. And as Louise pointed out, often what we hear are families asking the same thing over and over again. Do everything. We want our father and our husband to return to how he was before. And as Louise pointed out, it's a call to create meaning and understanding out of a situation that's probably very complicated, tragic in many ways, confusing. And in the end, I think both clinicians and families are trying to find a place of integrity, to be a good husband, a good wife, a good son or daughter in the midst of this complicated situation. I think that's true for clinicians too. And if you think about the questions that we ask over and over again, it goes to Lee's point. It's often in our moral distress that we say, why are we doing this? Why are we doing this? And in a similar way, it may be that that's our call as clinicians to try to make meaning out of a situation that is confusing and complex and has a lot at stake in terms of how we see ourselves as doctors and nurses and social workers and chaplains. So I think it's worth acknowledging that in a way we're all in the soup trying to find some anchor in integrity for all of us. So how do we shift the dialogue? And I think this is a struggle that many of us have. We sort of ask the same things over and over again ourselves. And in some work that our colleagues Doug White and Bob Arnold have done, they've looked at some of these conversations. And one of the common narratives on the part of clinicians is our question of what do you want? And what that is sort of rolls off our tongue. What would your husband want? What do you want? And in looking at their own research, they have found that that is actually not a helpful phrase. Because what it does is it sets up a situation where we say things, do you want everything? Well, most people are not going to say, you know, if you've got something that's going to help, I'm not going to do that. So it leads to a series of expectations that may, in fact, not be consistent with what's actually possible. It also sounds like we're talking about a menu. So what do you want for dinner is a different question than what do you want in terms of medical treatment. And it sort of takes people into a way of thinking that doesn't invite them into the dialogue around how do we actually make trade-offs? How do we understand these various options and what we're really trading off? Quality of life, length of life, pain, suffering. How do we even think about that? It's also, they suggest, possible that asking questions like, what do you want, can shut down conversation. Because once they declare what they want, then it's up to the team to say, well, are we going to agree with that? Are we going to not agree with that? Are we going to challenge their want or not? So it kind of sets up it can set up a kind of adversarial kind of relationship. It also engage our aspirations and sometimes our fantasies about what might be possible. And so that tone of conversation can also engage, we want him to be like he was 6 months ago, but actually, from a medical point of view, all these comorbidities suggest that that's actually not possible. That what might be possible is some level of functioning, but nowhere near what he was able to do prior to coming. So what they suggest is to shift away from what you want to, for example, asking the wife, what would your husband say about his serious illness? Or what would your husband tell us about his situation if he were able to speak to us? And I actually have used that a lot in ethics consults with families of, what would your mother tell us if she were able to talk to us right now? What would she say about her current situation? And one of the reasons that that can be helpful is it also helps families to not be quite so embroiled in their own emotional response. This idea of I want to be a good wife and a good son or daughter, but engaging them in a different kind of conversation, bringing it back to focusing on the patient. Because what we hear from surrogates a lot of times is we want everything. And sometimes that is even contrary to what they know to be true about how their loved one lived their life or what was important to them. And it becomes more about their own needs rather than saying, this is really a decision about your loved one. And your job is to represent what you know to be true about them and their lives and their values. So that's one piece of it. Another point I'd like to make is that we often relate to conflict as failure. And when we experience these kinds of conflicts, it feels like we've done something wrong or something hasn't gone right, and we have a negative relationship to conflict. On the other hand, conflict is expected. There's different points of view here. The team, different clinicians have different points of view, and different family members have points of view. So one question is, how do we create space for those different points of view so that we actually can understand each other's points of views differently? So families get attached to the I want to do everything, and every time we have the conversation, they are just digging their heels in about that. And the team, we can also dig our heels in. And so one question is, how do we create a space where we can appreciate the different points of view in a way that takes us forward rather than keeps us stuck in the same dialogue over and over again? Many of you had those conversations, like we've had this conversation and we've had this conversation and it's still not moved us anywhere. Another point is there's an interesting study in JAMA Oncology in 2015 that looked at over 5,000 encounters with oncologists and their patients, looking at the questions of inappropriate, requests for inappropriate treatment. And the findings are pretty interesting. First of all, the incidence of truly conflicts or differences of views is relatively small, less than 10%. And really even have conflicts or requests for treatments that clinicians might view as questionable. Even less than 1% of those actually involved cases like this. So the point is that this happens relatively rarely in our experience, and yet we remember it and we give a lot of our energy to addressing these sorts of issues, partly because these are cases that take time to explain and to engage in dialogue. And the other part is that sometimes we can experience as clinicians that there's a lack of trust when family members are questioning what we're recommending. And that engages a part of ourselves, our identity as a clinician. It also engages our sense of, competence. So important to try to keep these in perspective, how much energy we put into these cases, and at the expense of noticing the large majority, over 80% in this study, of cases that actually go pretty well. So it's somehow balancing our attention and meaning to these kinds of cases. I think I'm going to stop here.
So we're going to turn it over to you. So are there comments or reactions to anything that the panelists have said, or questions that you have, or how would you handle these kind of cases?
This is such an interesting case, and to the panelist's point, I think this happens very often here. So I'm wondering if maybe it would be helpful to consider a different kind of intake for patients who are transferred from one institution where we maybe don't have a relationship that exists with the patient or family, or even the community hospital to a degree. And patients who come to us who have been long-term patients here, who then end up in this unfortunate series of situations. And I wonder if we can think of this sort of systematically in terms of what do we do for patients who come to us who are unknown to us, who are transferred, because that's a big part of what we do here. And I think it must be very challenging for all the providers because they're starting from a catch-up point.
So I think there may be two elements to that, and then there may be more. We'll get to hear from the panel. But one is expectations of the family. So their prior experience at another facility, and now coming here, what are their expectations? So maybe you could talk about that. And then second, Louise, you were talking about this in your presentation, of what's the sort of decision-making dynamic within the family, or what's been their experience with prior illness. So it's maybe a little bit more fact-gathering about this family rather than just the medical treatments of the patient. So anybody want to comment on any of those aspects or others?
Yeah, Jane, I agree with you. I think there's incredible value. We spent a lot of time hearing this case, and we certainly put a lot of detail in about the medical. But almost purposely, we didn't put much in about the family, because I think that's, in fact, Jane's point, is that you don't know very much. You have a great deal of the patient, but you really don't know how this family functions and what occurred at the other outside facility or hospital. So the value of taking a step back and gathering as much information about that family as possible can be a tool, to Jane's point about doing perhaps a different assessment. I'd argue that that's valuable for all patients, not just outside transfers, that perhaps we would do, we'd have a better and easier way of dealing with patients and families if we took just a step sideways and backwards to look at our second patient. And I argue that there's almost 3 patients involved in this handout. There's the noted patient who we have the narrative about, but I think the second patient is the family. And the third patient that we don't spend very much time talking about is in fact the staff. If we look at ourselves as a patient, and we think about how we are doing as a team and how we are doing as a family within that team, we mirror some of the same family dynamics that we've all read about within our work set. And so I think that oftentimes in cases that we have 3 unique patients all simultaneously in care. I would also offer for your consideration is that this family has to survive. They have to be able to survive and survive well enough to be able to move forward in life. And sometimes our medical decision-making is suggesting that we limit care in a particular domain, that we do a procedure in another domain that the family may or may not agree to. In the end of the day, they have to be able to live with that decision for which they make, be able to go back into their own community and explain the decisions that they made or did not make. And that's a dynamic that is very tender for many families. There can be, Cinda suggested that families are in a position of looking at a laundry list of things that they would like to have done. So what would you like us to do here? They don't really know. Their often only exposure to some of this complexity of medical care is from a television or a movie perspective. What does that look like? It looks like everybody survives CPR. It looks like everybody survives intensive care, and almost the next screenshot is that they're up and walking. And that's their vantage point. And we ask people to make very complex and hard decisions on someone that they care about. So I think if we look at the fact that we've got 3 patients in the room, it may help us.
I think there definitely is value in having the information that you talk about, Jane and Louise. I think one of the things that just to sort of like what's running through my head as we're talking is the question of who's responsible for obtaining that information. Exactly what information do we really need, and at what point in this process does that information get gathered? I think it's pretty clear that, at least in the case as described, what we do about the family is too little and too late. But I think there's a real challenge here in trying to figure out what do we need to know and when do we need to know it. And there's some very significant operational constraints. It would be wonderful if there was a family file that came with every patient who was transferred by HAL, but there are already a tremendous number of barriers to getting people transferred, and there will be little appetite for slowing down our transfer process any further, which I think would be difficult not to do if we were to try to do that at that point. And so I'd be curious about sort of creative thoughts about how we can do that, get that information early on, and what that information should entail.
I'll just do a follow-up question, because I think it pertains to the staff and the clinicians caring for the patient. We can do this, but should we? So in these conversations with family, if they are the decision makers, how would you suggest the clinicians present the options, if there are options? What kinds of recommendations would go with listing of that, various laundry list of things we can do. Any suggestions along those lines of engaging families with the complexity of the trade-offs and so on in making these decisions?
That's me again. So I think making lists of anything is probably a bad idea. Was that a leading question? That was a leading question. I actually will often explicitly use the language that we talked about. There are things that we can't do, that doesn't mean we should do them, but we don't take that to the, for example, we could do this and this and this and this. That is unhelpful. But rather framing things in, the context of all the things that we are doing right now are things we, often that conversation gets framed as that we could continue to do these things, for example. Or maybe because we have tried and we've not seen a benefit from them, we should not continue to do those things because they're not helpful. So, yeah, I think I'm repeating myself here, but just lists are not helpful. I think the constructs tend to be more helpful. And I think it's most helpful, at least in my experience, to talk about overall trajectory and direction as opposed to very sort of specific interventions. Sometimes we use an example of a specific intervention as something to be on a given trajectory. If we were to continue to be very aggressive, we might do X. If we felt we wanted to prioritize comfort, then we would do Y as an example rather than as a sort of specific laundry list of interventions.
Yes, I'd like to ask a question. It was mentioned that many patients come here with the hope that they will get better. And the question I'd like to ask is, has there ever been any systematic study of how, in fact, most effectively manage patients' expectations when they initially arrive at this institution? They oftentimes, we obviously want to ensure that they have hope, but not unreasonable. And just as Cinda mentioned that there are certain phrases that can be helpful when you're discussing like decision-making, my question is, has anyone systematically looked at phraseology for ways to talk to patients and their families on these initial interactions?
So Peter, I don't know if there's been systematic study. I think that through experience, we have found some ways that sometimes even asking a question about expectations can be really a helpful beginning. Because to put that right out in the beginning is a way to either build or break trust. Because if they have unrealistic expectations from the beginning, then it's likely that they're going to feel disappointed about what happens. And is that not an opportunity to clarify what is actually possible? While, we understand that you want your husband to return to how he was before, that is not a realistic goal right now. Here is what is possible. And getting that clear may be a step toward ongoing conversation, going back to here's what you are expecting, and managing those expectations means that we have to clarify when the expectations are actually not possible.
My comment is, I'm speak Peter, Peter. Peter is back there as a mentor of mine, so it's a little bit of a softball. I'm not aware of any of those studies, Peter, but I think it's what we should do. So, and it seems like actually a pretty straightforward. I'm like running through my mind, like, how could we get that funded? Mark, let's talk about that. And I think, but I think it's, as we talk, I mean, it really is that setting of expectations. It's really critical. And I think it'd be very interesting to think through how we could systematically study a way to sort of establish, a script of sorts that allows us to intervene very early at the time of transfer, setting expectations, and what the experience of the sort of overall experience of the patient-family interactions with the provider team is, having done that.
So the one thing I would say in terms of research, Doug White's group at Pittsburgh has a large shared decision-making series of studies, and have done some really excellent work in that area. Tony Bach and colleagues at Seattle have also done a lot on communication, and that would be at least where I'd start in trying to look at what we know.
What has been described about this case, the patient, his condition, and did go in and out of times when he was with it and could communicate well. Has an attempt ever made when a patient comes in without the advance directive, take advantage of those interludes to get an advance directive from the patient himself or herself?
Yeah, I think that's a great suggestion. If you know, so part of your triaging of the case is that an advance directive hasn't existed. You'd like to have some exploration of, well, did you as a family ever discuss this? So going back to previous conversations, maybe when he was diagnosed with the prostate cancer, did you have any conversations about what if things got more serious with your cancer? Or again, had he had any previous hospitalizations or serious illnesses where these things might have come up? So that's one. But then during the hospital stay, I think is to your point, are there periods of lucidity where he is relatively stable? We're hearing that he's got a tracheostomy and he's on a T-piece, but are there opportunities for a speaking valve, that he could communicate or write when he was more coherent? And then it's a question of how do you ask him about these quality of life versus quantity of life versus overall goals that he might, again, we're asking the family, what would he say if he could speak to us? Those times when he can speak to us, what does he say? I think that's a great suggestion.
I think just in response to that, practically one of the challenges is the nature of delirium is such that it waxes and wanes. And I think, having been in those situations where you're really desperate to know what the patient herself would say, we do often sort of rush in when we hear the patient is negative and responding. But it's very difficult because things wax and wane so often so quickly to feel really confident that the information we've gotten, even in that period of apparent lucidity, is a clear expression of a consistent wish. It's hard.
I'm hoping someone on the panel can talk about how, either for the family or for the hospital, financial considerations might impact this discussion or decision.
So we have the family perspective and then maybe the institution.
Look at the time.
Okay, so let's just take a quick run at the family. We're going to, again, assume that he's 71 with Medicare and not working. And we're going to hope that there's a secondary policy. If there's not, then this family is facing a tremendous outstanding balance at the former hospital and at this one. And so to your point, what happens to the financial impact of healthcare on families and patients? And the popular press is hot to talk about what the financial burden of healthcare medications and hospitalizations are for Medicare recipients and others alike. So that's a very good point. What is the financial burden going to be to the spouse, not to the children? The spouse is the only party responsible for the outstanding balance if this man does not survive. likely, again, we're gonna fantasize just a little bit, but likely the outside hospital was having a conversation about plateauing in healthcare and wanting to transfer him at that 2-month mark to an extended care facility on a ventilator. And that likely generated the request to transfer to Hopkins. That's not a terribly uncommon point where families feel like the message is that you are leaving them, or their sense of perhaps abandoning their healthcare loved one. And we're back at needing a transfer to another kind of facility. And so, again, that family may have been approached by the hospital to look toward the disposition and discharge to a facility. Again, I think the emotional impact is very great on the family side. Whenever we are transitioning points of care, it's a tender moment so that it's not being perceived that we are walking away.
Louise, can I ask, do you think, in terms of our triaging, the family should be asked, perhaps by a social worker, are there any financial concerns that you have with regard to the hospital stay?
So just to put a plug in for the discipline of social work, this is a case, as well as I'd argue most of the cases, certainly here at Johns Hopkins, that we should be seeing a social worker providing a psychosocial assessment. These are critical points, particularly transfer families, particularly transfer cases that we're describing here. So a social worker would have been able to, again, figure out how that family functions, who's in the family, how do they make decisions, and that wide breadth of psychosocial assessment would have given this team some information about the structure and the dynamic of the family, about the finances of this family, about what other burden. Was this a family that's about to be foreclosed and these bills are about to tip over that family? It'd be useful to know that. Not that it would change the healthcare decisions that are being made and should be made independently, but it would be a part of consideration and part of the discussion to understand what that family's going through and living through and about to survive as the outcome.
I think just two other quick comments. I think we'd like to suggest that, finances have nothing to do with the decision making, but I think that we live in a practical world with budgets and a bottom line. It is true that this patient's insurance would have been assessed at the time of transfer. Did they have insurance, and was it, what the specifics of that were? So that's, the transfer would not have been independent of that. As a provider, we can ask for an override of insurance assessment, and that involves one of those awkward conversations with people on finance. Sometimes not so awkward, but occasionally they can be rather intense. But that piece certainly would have played to it. It played into some of what happened, at least at the time of transfer. The other comment I'll make is to share a personal story. The first experience that I've had in 12 years of practice, just last month, of a family member bringing up finances and a decision about whether to give consent to a specific therapy. And in that, there was a particular therapy that was being offered, and she wanted to know, the family member wanted to know if it was going to be covered by insurance, because that would have an impact on whether or not he was decided to proceed. And that's actually the first time I've had that. I'm not suggesting that those conversations or thoughts have not been had internally, but the first time I've actually had an explicit conversation about that as regards to a specific therapy.
So I think financial concerns and costs are on everybody's mind. And I think one of the challenges that we all have is how do we avoid making decisions on a case-by-case basis without a larger framework that our society has endorsed. And given where we are at the moment, the possibility of that seems pretty dim at this juncture. And yet at the same time, one of the risks of addressing these problems at the bedside is that we could fall into patterns of discrimination or using criteria that maybe aren't completely transparent, even to ourselves, you know, where our biases begin to shape the way that we make decisions, consciously or unconsciously. And so I think one of the things that we've always worried about is that reality, and how do we protect against it? What would be some of the mechanisms that would be standardized that we want to put in place to begin to at least move in a direction of fairness and transparency? So I think those are tough questions, and ones that we need to struggle with as we try to balance the competing obligations here to our stewardship, to our institution, to society, and importantly to the people that we serve. And how do we engage them in making decisions that are right for them? You know, so some people may want to have that kind of a conversation, and other people may be completely repelled by the suggestion of it. And so I think it's one of those areas where we're going to have to figure out how to navigate, and we're probably going to find it not to be a straight line or an easy path.
I know we're short on time, but I want to, sorry.
Sorry.
Real quick. I know we're short on time, but I want to go back to the list situation. I, as a family member, might like it if someone said, here's 4 options that we can do. If we do A, he could get better, you know, or this could happen, or even a worse outcome. And we could do B, same thing, and sort of give the family member the idea of what could happen if they perform certain procedures. I certainly don't want a procedure to be done that may help my dad, but then also might cause him extreme pain, that, you know, irreversible pain, that sort of thing. And I think a clear-minded person would be able to listen to that and say, well, you know, the options are not so great that he's going to live. I also would want to think that the doctor's not just telling me gloom and doom. We could do this, but then this will happen. He also better say, but then this could happen as well. Otherwise, I really don't want to hear him, because you understand what I'm saying. If it's all bad outcomes, I'm not going to really believe that. So I want to hear a little bit of good in there also. That's it.
We'll take.
First off, a comment. I was just thinking about my time. I had worked at a rehab hospital for a long period of time, and obviously that's a bit different setting, but we did have patients on ventilators in different sort of complex situations that often had been well prior to, you know, a traumatic accident or something. And one thing I think that we did that seemed to work well was we did ask the families what their goals were for their family member, and then during maybe like a several day period, the different clinicians that would be involved in that person's care would kind of develop their goals, and then we'd have a team meeting with the family and kind of discuss the goals for the mission. Obviously, that's a rehab setting, and things still were fluid sometimes. Someone would get, you know, a pneumonia or a different complicating situation, and then we'd have to switch things up. But I found that, especially when we had someone very complex, if there was any ability to have like a hospitalist or someone that was always going to be there, at least overseeing that patient's care, that seemed to benefit the families. And then also doing what we could from the nursing perspective. I'm a nurse, providing like a primary nursing team even, because just having one was, you know, go on a shift and different things like that. I guess what else I wanted to say is that something I personally found useful as a phrasing was that so often people say, oh, I want my family member to be better, to be who they were, to be how they were, and often that is not possible. And I found sometimes it was useful to say, I want that too. I wish that, you know, I wish for that for you also, you know, and here's where we are today, and you know, it's okay to maintain that, both of those things, that hope for the very best, hope for the miracle, you know, that's okay, and let's plan for the reality of where we are today. And sometimes I found it would help shift, maybe even just the relationship with a family member, that they didn't think I was trying to shut down their wish or hope. And I guess the question I had is just in terms of, I find it always helpful to know you're not alone in something. And I know longer term we can get people hooked up into support communities or, you know, things like that. And sometimes families form their own in the, you know, family lounge, and sometimes that's helpful and sometimes it's not. But, you know, I don't know, do we have any ideas around getting people hooked into support communities, even in the midst of, I don't know if it's possible.
So, I think you're referring to the patient side, but I just want to link that to the clinician side. So one of the things we found in our moral stress work is that having what I would call relational integrity with our team is really important. Knowing that we have each other's backs, that we are, even though we may see the situation differently, that we're actually working together to find the best solution. And that we're not alone. The sense of isolation, I think, for patients and families and for clinicians who are struggling with moral distress is an issue. And so creating forums where we can have conversations about patient situations, sometimes our ethics consultation. We always wish we were called earlier than after the patient's been here for 4 months. But part of our goal would be to create a place where patients, families, and teams can come together and explore some of these different perspectives and to try to clarify goals and values in a way that will help us in the long term. So I think anytime we can have patient care conferences, anytime we can connect patients with other support systems, but also the staff as well.
I'm just as old as I look, I want you to know. I'm maybe out of date. I graduated from this institution 50 years ago, started at Homewood and finished on Osler, so I love this place. I'm appalled at what's happening. I happen to practice, or did practice, in Northern Virginia. And we've had a new clinical ethicist join our staff. And I'm appalled by the fact that she uses statistics to analyze clinical problems. And I'm appalled because as soon as I learned about this, I realized that I think that statistics deprive individual patients and family of autonomy. And I've been listening to you all, and I admire everything you said and appreciate everything you said. But in a different way, all of you are reflecting data, additional things about the family, different things about their financial background, etc. And I'm wondering what you think about applying statistics in terms of how the last 100 patients in this situation were handled should apply to the case before you at the moment.
I would say I'm not a fan of that approach either. In part because in some ways I think it is a defense mechanism on our part to be in a place of comfort with numbers so that we don't have to have the really difficult conversation about what's at stake. So I think sometimes it can be helpful in framing a sort of general understanding, but my background's in pediatrics, and a lot of times parents will say, you know, that's great, but my child's going to be the one. And so I don't think that patients and families relate to our numbers in the same way we do. And I think sometimes it can create a wedge because we get kind of attached to our numbers instead of really having the more human conversation about what might be interesting for them. So I think they're useful. I'm not personally someone who thinks that gets us where we need to go. Lee? How much?
I mean, there are a whole host of different ways that statistics can be used to inform these conversations. If we're talking about looking at the last 100 ways, you mentioned the last 100 ways, the last 100 patients' lives handled, there are some actually, probably some useful statistics. For example, for, the 75% of patients who had this type of framing conversation that set expectations earlier on, the overall experience was better. I think that's an important statistic. If you're talking about specific outcome statistics, I think that many families will want to know those statistics, but only as a background to this conversation. With X disease, we know when we look at a population that 50% of people will survive. And then actually an explicit conversation that acknowledges the fact that we're only talking about one person. I think people I would like as a patient to know what the overall numbers are. But having been a patient myself, I can tell you that that's not the only piece of the conversation we want to have. And that we need to take that statistical information down to a very real level. I have had one particular mentor who has always reminded me that there is no 80% survival rate for one person. You either survive or you don't. It's 100% or it's 0. And so you're right, those numbers don't mean a lot. But I think, again, setting a background picture, as Cinda has suggested, is important if we carry it into, this is what I know about everybody who has this disease, but let's talk about you. And then I think that places that information in context that is helpful.
Okay, well, thank you all for your participation. We'll see you next month for another episode.